Welcome, everyone, to a discussion with state leaders on Medicaid unwinding. We're so glad you could be here with us today. We're just going to give everyone a minute to join us and log in, and then we are going to get started with this great discussion. Okay, welcome everybody. We are going to get started. We see we have a good group here. Over 200 people have logged in to this webinar. Welcome. I'm Hamie Tawarson. I am the Executive Director here at the National Academy for State Health Policy. And I really want to welcome you to today's event, which is a discussion with states as they plan for the end of the COVID-19 public health emergency, and specifically the resumption of normal eligibility determination processes in their Medicaid program. I wanted to start off the webinar by thanking the Robert Wood Johnson Foundation for their generous support and their support of NASHB's work on both health coverage and population and public health issues. I know we all know Zoom, but before we get started, I did want to just quickly go over some housekeeping details. We are recording this webinar, and that recording will be posted on NASHB's website along with the slides after today's event. Also, there will be time towards the end of the webinar for an audience Q&A session. So please, you can ask a question by clicking on the Q&A tab located at the bottom of your screen and type that in. We're going to do our best to get to as many questions as we can, but given the number of people on this webinar, just understand that we probably can't get to all of them, but we will try. We will certainly get to some of them as we move forward in this conversation. And I am so pleased that we will be talking with 3 state officials here today who are going to offer their perspectives from their different coverage programs. And that was really important for us here at NASHB to really present different perspectives across Medicaid, state basic changes, and CHIP programs. I'm going to introduce these folks, and then when I'm done giving a quick overview, we're going to all be on the screen, and you'll be able to see all of us as we have the conversation. Our first guest will be Audrey Gassier. She is the Chief of Policy and Strategy at the Massachusetts Health Connector. Our second guest will be Maribel Kluckman, who's the Eligibility Division Director in the Colorado Department of Healthcare Policy and Financing. And then last but certainly not least will be Jeff Nelson, who's the Director in Utah's Children's Health Insurance Program and Bureau of Eligibility Policy, Division of Medicaid and Health Financing. So I think as we get to this conversation, I think we're really going to be excited to learn about their plans, including strategies to ensure that eligible individuals do not lose coverage when the Medicaid continuous coverage provision is no longer in effect. So, but before we dive into the discussion with states, we thought it would be helpful to provide some brief background and context. As many of you probably know, the Families First Coronavirus Response Act provides states, which was passed in March 2020, provided states with an increase in their federal Medicaid matching dollars if states complied with certain maintenance of effort requirements. Those requirements included a continuous coverage requirement, which prohibited states from terminating Medicaid coverage for individuals who are enrolled as of or after March 18th, 2020, unless those individuals requested to be disenrolled or move out of state. This provision has been critical during the pandemic in providing stable Medicaid coverage for millions of individuals at a time when many of those families face tremendous financial and personal instability. The Kaiser Family Foundation has done some work to understand the increase in Medicaid, and they have determined from February 2020 to September 2021, there has been an increase of nearly 14 million people enrolled in Medicaid across states. One important point that I did just want to highlight for you all is that the continuous coverage requirement expires on the last day of the month that the federally declared public health emergency ends. But with the FMAP increase and other maintenance of effort requirements, those will not expire until the end of the quarter in which the public health emergency ends. I wanted to just also talk a little bit about, a little bit about talking about, although the states are not disenrolling individuals from Medicaid during the public health emergency, states are regularly reviewing individuals' eligibility and renewing their coverage. A recent survey of states' Medicaid and CHIP eligibility and enrollment policies conducted by the Kaiser Family Foundation found that 41 states reported processing automatic renewals to extend Medicaid coverage for individuals during the public health emergency. 28 of those states are contacting individuals when they are unable to confirm eligibility through electronic data sources. And some of the state systems are flagging individuals who are either found to be ineligible or whose eligibility cannot be confirmed, such as things due to outdated eligibility data, to help them identify those individuals for further action after the public health emergency ends. So I guess, the message here is states continue to do work they have during the pandemic, and they continue to do work to plan for the, upcoming end of the public health emergency, whenever that may be. And I do think during the discussion, we're going to get into more about what exactly are states planning and how are they moving forward. Slide, please. I did want to just talk a little bit about the challenges. So the big challenge facing states is that there are many tasks and anticipated obstacles involved in unwinding public health emergency policies. The execution of those plans remains difficult when we don't have certainty over when the public health emergency might end. States have been actively planning for quite some time now to prepare for the end of the PHE and the end of the Medicaid continuous coverage requirement, but they do remain in a state of limbo without a clear timeline. CMS is very focused on this topic. It is one of their top priorities across the agency, and they have issued guidance and provided tools to states to help them plan for the end of the public health emergency and resuming normal Medicaid eligibility determination processes. Some initial guidance was provided in December 2020 with updates and important changes released in August 2021, which included giving states up to 12 months after the end of the public health emergency to resolve pending eligibility redetermination issues. The guidance also required that states conduct a new eligibility redetermination for all individuals prior to disenrolling them. And just last week, CMS issued additional guidance. And while we're not going to be going into all of those details today, I just wanted to mention a few things. It reinforces much of the August 2021 guidance, but there are a couple of notable changes that I just wanted to highlight. One is it gives states an additional 2 months, so it's really up to 14 months to complete all work initiated during their unwinding period. And they also, the agency also emphasized the importance of ensuring that individuals who are found to be ineligible for Medicaid are smoothly transitioned to other sources of coverage, which could include through the health insurance marketplaces. I think this is something that's very important to state officials as well. They really do not want people to lose coverage when they remain eligible. And they really are making a lot of plans and efforts to try and ensure that eligible individuals will remain enrolled in the coverage for which they qualify. I did also want to just mention CMS did recommend that states not initiate renewals for more than 1/9 of their caseload in any given month, and that they should take a risk-based approach that prioritizes those who are likely not to qualify. Those are two additional considerations for states as they think about planning for the next steps of the end of the public health emergency. So now I wanted to bring on our state officials so we can really have a conversation around what everybody is thinking about as they move to the next steps in our continued journey with COVID-19. So I wanted to just ask a general question for you all, and I'll ask for each one of you to just provide your thoughts and reactions. So how are you planning for the unwinding of Medicaid continuous coverage in the context of the current uncertainty about when the public health emergency will end? So I might start with you, Maribel, and then we will go to others.
Sure, thank you. Good afternoon and happy Friday, everyone. So for Colorado, we have a lot that basically our goals and the heart of everything that we're doing is, continuity of coverage. How do we make sure that, and as you touched on right now, having the best member experience as possible, and the best experience for our eligibility workers, our workforce as well. So we have quite a bit that we've been thinking about. If we were to break it down in three buckets, we've been focused on systems. Also taking it as an opportunity maybe of how do we not only prepare for the end of the public health emergency, but our experience even beyond the pandemic. We also have a lot of, we've been casting a really wide net and partner engagement, and really taking it as, we're all a village, and how do we collectively come together to brainstorm and think about ideas. So we have quite a bit of the actions that we've taken over the past year and a half now that we've been working on this, based on the engagement with partners. And then also thinking about what else can we do to support our workforce. And yes, we're all experiencing, the great resignation and workforce shortages. So that's what we bucketed. I'm not sure, Hemi, if you wanted me to go to details right now, or maybe just at a high level. That's kind of where we're at so far.
Yeah, I might just ask you one follow-up, and then I do want to bring in Jeff and Audrey into the conversation.
Sure.
So, I think everybody is so interested in how are the states really planning for this? Like, what are they doing? And are they, are they prioritizing populations? And are they going to release, a public plan so we can all understand what's happening? And we're going to get to the question about partnerships with plans and other sort of later in the conversation, so maybe not focusing on that, but are they going to track disenrollments and slow down their process if that, if there's an uptick in those numbers? So maybe providing a little bit more flavor along those lines of what Colorado is thinking about.
Sure. We were really excited to see the CMS guidance. We had been engaging with them in the conversations about what our challenges were at that time, as far as, going from the 6-month guidance to the 12 months and now seeing the 14 months. So right now for us, the 14 months is in great alignment into our plans. So our plans have been, let's go through our normal renewal cycle, so that we can distribute the work evenly amongst the 12 months and not have to stack on some work. Within there, we're also thinking about what are the special populations or focus populations. So, we're planning to implement the postpartum option, moving from 60 days to 12 months. So depending on the end of the public health emergency, how do we make sure that we protect them during those, while we're making that transition? We have some focus as well around, our homeless population. We're thinking about our Medicare individuals that may be eligible. Some of what we've done is we've definitely done some rework of our renewal process to make sure that we're in a better place with our renewals, such as reformatting our renewal packet. We have a whole new packet that's about to be released next month, so that members will really be attracted to it, hopefully, and get that goal in mind of continuity of coverage so that they can return the packets to us.
Thank you. Thank you for providing that. Jeff, I'm going to turn to you next, and you're going to provide a different perspective from Utah and your CHIP program.
Sure. It was 2 years ago today that Rudy Gobert, the center of the Utah Jazz, came down with COVID. We didn't know what that was then. It stopped the entire NBA from having a game that night, and not just that night, but it, put them in the bubble, all that fun stuff. So 2 years ago, that's crazy to think that time has gone like it has. But back then we knew nothing. And very quickly we were trying to move, just like everybody else, to keep our Medicaid program open. And we went to hit the magic button in our system that kept all those cases open, and we found we didn't have one. And I think every other state was in the same experience that we were having with that. But we did decide to include our CHIP program and keep them open just like we did with our Medicaid program. So we went through that process. It signed a SPA with our friends at CMS. And over time, we kind of learned that wasn't what we could do. They didn't have the authority to do that. So unfortunately, about a year later, so a year ago in April, we closed or undid the button, if you will, and were unfortunately had to return to normal for CHIP, and we did so very, very quickly. What that ended up with in our state from the CHIP perspective was a 41% drop in coverage. That was horrible. That was not what we expected. So the question was, what are you doing to plan? And our first thing was, well, right away, we started thinking very, very differently about what was going to happen with Medicaid. And we started meeting last year now, about what might happen using the guidance that we had and how we would move forward to make sure that we were communicating better to the clients themselves, to the members we serve, that we understood the processes themselves, and much like Colorado, that we're working to see what can our system support to help us out. And very fast, we learned we don't even have a good scope of the problem. So you mentioned earlier flagging. We're one of the states that has decided to go and flag. And I know that sounds negative. It's not meant to be negative. It's just simply indicating these are those cases that we don't know what's going on. In Utah, we did keep our renewals moving forward, and that has occurred. So we kind of have two populations. We have the population where we know you're eligible and we know that things are roughly okay, and when your next review date is. And we have this other population of held open, frozen, flagged, whatever we're going to call that. We have this group of the population that is about right now 31% of our population overall that's being held open. And we know that we need to understand, now that we can understand that helps. How do you now re-engage and put that plan together? So we're working the same things you're talking about. We have written a plan. We're talking about how we're going to share that and be more transparent, because I don't want to have another news story. It's just not a lot of fun overall. And I'm hoping that we can at least do this better than some other states. No offense to the other states that are out there.
That sounds great. Can I ask you one other follow-up? And then I do want to hear from Audrey. What do you think about sort of dashboards? And are you thinking about using dashboards, as you roll out this process?
We absolutely are. That's one thing that I think we learned very quickly from the CHIP situation, was that people want to know, well, what happened? You closed 41%, but what does that mean? So our thought is to be as transparent as we're able. It's funny when you start getting into eligibility and closure reasons. I mean, the reason that a worker happened to close that particular case doesn't necessarily tell the story of why that occurred. I mean, moved out of state doesn't mean anything. Did they go get a job somewhere else? Are they on benefits somewhere else? It doesn't tell you much. But we can tell you how many cases, for example, went to the exchange, how many cases didn't complete paperwork, and that was why they didn't remain eligible, how many people stayed on the program they were on or moved on to another Medicaid or CHIP program. So we intend to at least show that much information month to month. Our intent is to also show what our hearings are doing, what our call volumes are doing. We want to give a better picture of what's actually occurring, because this is going to be a busy time for any eligibility agency. And it's not fair to look and focus just on this one aspect of the work. You really have to focus on what's happening kind of globally in that area.
Yeah. Thank you for sharing that. One last question, then I'm going to turn to Audrey. Are you thinking about prioritizing certain populations as you sort of roll out this process?
We definitely are. And I think that it's important to understand the state characteristics matter here. If you're an FFM assessment or a determination state, if you have a separate CHIP, all of those things, every program is so different across the states. And some things that are very easy for our state might be very difficult for another. And I think that's always interesting. But our intent is exactly, I'm sorry, I lost track of the question a little bit. Sorry with that.
Prioritizing.
Oh, sorry. As far as yes, yeah. Our intent is to prioritize. What I was going to mention was that in our state, we have a combined eligibility system, and we look at all different programs, including SNAP and other things, which, by the way, have their own things going on when the PHE unwinds, which is interesting. Yeah. So because of that, we're focusing on three things, and it's kind of a mixture of the three. We're looking at what is the utilization? What are people using of their Medicaid benefits or not? And we think that's an important factor. The other factor is how long we have held them open. So we have in our states around 140,000 individuals that we're looking at. So we're looking at how long they're open, how are they using the benefits, not using the benefits, because we think that might be telling us something. And then finally, we're trying to make sure we have a good cross section of programs so that we don't give any one program to our eligibility agency. So they have separate teams in our state, and we want to make sure we don't overwhelm any given team. So it's that combination of efforts there. It's a lot. It's a lot to try and even make that calculation has been very difficult.
Yeah. No, thank you for sharing. Audrey, you're going to provide the perspective from the state-based marketplace. So
sure.
You.
Great. Well, good afternoon, everyone. Thank you so much for coordinating this conversation. It's great to be here. So my perspective is after all of the work that Maribel and her counterparts and Jeff and his counterparts are doing, state-based marketplaces and of course the federal marketplace have an incredibly important role to play in the context of this transition when the public health emergency does end and these redeterminations start to kick off, because of course marketplaces can be a landing place for people who may be losing Medicaid eligibility or now in a different circumstance in terms of their income, may qualify for subsidies through a marketplace, maybe no subsidies through a marketplace, but that's the best place for them to maintain their coverage, even if it's an unsubsidized qualified health plan. So we see this as an incredibly important endeavor. It's very high stakes, thinking about it in the Massachusetts context. We are working hand in glove with our Medicaid counterparts to get ready for this transition. So a ton of work is already underway in terms of coordination, planning, information sharing, strategizing. Once that starting gun does go off, what that kind of handoff process will look like and how we're talking to these populations who may be going through these eligibility changes in a way that is in sync. And we're sending messages and communicating to the public and these populations in a way that is as likely as possible for these people to take the actions necessary to move from Medicaid to Marketplace if that's the right eligibility change for them. So some of the places that we're doing the most work are, of course, us understanding who's in Medicaid right now in this kind of protected status. Right now, we can see that in Massachusetts, there are tens of thousands of people that do have an underlying qualified health plan determination. So we're getting ready from an operational perspective to intake many tens of thousands of people. So that, of course, involves preparations from a customer service perspective, making sure we, our call center, our navigators are ready to support that population. So that's a big component of what we're thinking about. Another piece is communications and outreach. Of course, people will be hearing really concrete action steps from our Medicaid colleagues when the time comes for their redetermination in terms of concrete steps they need to take and the like. And what we want to be doing is using the best practices, data, evidence to make sure that all the messages coming from the state, Medicaid, and the exchange are kind of from the same song sheet. And are going to be delivered in ways that people understand, that are not overwhelming, that don't make assumptions about what people know about their coverage, is linguistically appropriate, culturally appropriate. And so I'll just touch on, we're actually planning to start to do some focus groups in Massachusetts to do some message testing. And again, of course, we're all operating under a somewhat unknown timeline, but what we're doing is working very quickly and hard right now to have a plan that is ready, including tested messages and the like, so that when the time comes, we're ready to go. So we're working on some focus group research right now. We're really appreciative that CMS recently shared some focus group and kind of interview results that they had done in terms of testing messages and trying to understand this population's understanding of the PHE and how it's affected their coverage, which I think was a wonderful starting place. It's great to have federal partners who are exploring those kinds of questions and sharing it so readily with states. So that's a helpful starting point. And then I think at a state level, because we're all unique, we have unique populations and approaches. How do we take that further, what the feds have done and started with, and make sure we go even further to tailor it to the populations we each serve. So that's a key focus for us in Massachusetts right now. And I will also note, again, in the spirit of states being so unique, we're very fortunate in Massachusetts. We have an integrated eligibility and enrollment system with our Medicaid program. So while, not to minimize how much work this will be, I think we're helped by the fact that we have this system that sort of the two systems are talking to one another and can kind of see across in terms of changes in eligibility. So the second somebody loses eligibility for Medicaid and is QHP eligible or appears eligible for an advanced premium tax credit on the exchange to make their coverage more affordable, we'll be ready to kick into gear, communicating directly to those people and saying, come on over, here's what you need to do, here's what your options are. Let us show you how affordable this coverage can be and exactly how to get into it. Look, here's a navigator in your area who can provide you direct assistance, et cetera. So that's kind of the waterfront of the work we're doing right now, which I would describe as a top priority for us at the exchange right now. We see this as high stakes, critically important, and see it as an opportunity to hold the line on coverage gains that likely happened during this public health emergency.
Yeah, no, thank you for sharing that important perspective. And you are right, Massachusetts does have the additional benefit of the integrated eligibility system, which certainly I think will help some of this work. So I wanted to just circle back. Those were all, I think, very helpful observations, and thank you for sharing all of that. So there are going to be challenges, certainly, right? No matter what you do, no matter how you plan, there are always challenges. And I just wanted to maybe just do a quick round robin, just amongst the three of you, of like, what do you think, at least from your perspective, are your top challenges or concerns with the unwinding? We've certainly here at NASHB from a number of different states and other stakeholders heard about, contact information for enrollees, especially those where the cases are open and you have to kind of follow up and find out, where are they? And then also when, enrollees receive the notice, how do you really engage them to do the follow-up work to make sure if they are still eligible, they can remain eligible. You've already talked about the state staffing issues and figuring out how to, handle the volume. And then of course, the uncertainty of the timing. So I'm just throwing out a few that have certainly come up in our various conversations. And Maribel, I might start with you to just kind of identify what are the top concerns from where you sit in Colorado.
Sure. As you mentioned, Hemi, I think one of our very top is our workforce challenges that I mentioned earlier as well. We are fortunate enough to have received some funding support from our joint budget committee with regards to being able to fund our county. So we are a state supervised county administered state, 64 different counties plus 10 MA sites. So that's a lot of support that needs to be provided. We received some funding to be able to support them with additional eligibility workers, whether they're hiring some more or maybe paying overtime or doing some temporary staff. We had some of this funding earlier, but our counties are telling us it's challenging out there to be able to hire right now. Especially when, I keep hearing the story of we may pay an eligibility worker $17 an hour, but down the street there might be a fast food chain that might be paying $17.50 an hour. And so, that creates some challenges and barriers. So we're trying to figure out how do we address that workforce shortage. As I mentioned earlier, we're not stacking up our workload, so at least the workload is still being distributed, but it's still, you mentioned earlier about 14 million individuals covered nationwide. For Colorado, 560 of those are provided in here in Colorado. So that's on top of our regular members that we cover. We've added an additional site that's state funded to be able to have somewhere to redirect work to go to. From anywhere, any of the counties, we can maybe have a state funded site, but will it be enough? We don't know yet, until we get into more of the weeds of it. So that's one of our top workforce challenges. And then the other thing that we're challenging, as you mentioned, is member engagement. There's a lot of work that's going on out there about how do we get the word out. I talked about the renewal packet, but is that going to be enough? Are members going to, hear us loud and clear? And so make sure that they're doing everything that they need to make sure that they have a continuity of coverage. So we're trying to explore and understand what other options do we have? How do we think outside the box to be able to really connect with members? We've done some text messaging. How much more further can we push that up? And how do we also leverage our tools that we have, right? So we just did a really big modernization of our online portal. How do we make sure that we promote that? First of all, make sure that the online portal is achieving our results that we want, a better member experience. And then how do we promote and push more towards that online portal so that members can, at their convenience, at 9 o'clock at night after the kids have gone to bed, they can go in and do the renewal or whatever it may be. So, that communication is critical for us. We have a wonderful communications team that is creating some toolkits to be able to share with everyone, and again, sharing the wealth on our village and spread the word for our members, but hoping that our members hear us about what are the next steps. Some other challenges that we also have and concerns is appeals. Granted the 14 months is to get through the renewal process, but what we're not talking about as often either is what about the appeals? At least for Colorado right now, we see, and my team might have to correct me, either about 100 appeals of eligibility per month. If you take the 560,000 and you divide it up by 12 months and you take even 1%, that's significantly higher than that 100. So, we've gotten a little bit of funding to increase our appeal staff, but I think that's still, 1% appealing, which is probably really low. It's probably gonna be higher than that. So we're trying to work through what does that look like for us? Do we have the funding necessary? I know there's some flexibilities that were provided within the guidance from CMS that we're going to be diving in a little bit deeper to see, is that something that can help us with this? But we're concerned about there. And then the other major concern we have as well is churn. What does churn look like? Again, challenge of whether members respond or not to the renewals. If they don't respond, they get terminated. So what's going to happen next time they need services? They're going to turn around and they're going to submit a new application. So, that's another unknown factor for us is we're focusing so much on the renewals. Let's make sure that we don't lose too much sight about what about the new applications and the churn that's going to come through with us as well, and what that increased workload for looks like. So quite a bit that I feel like we're in a pretty good place as far as all the planning over the 18 months. There's still more work to do, right? And those unknown factors, those uncontrollables is really what, as Jeff talked about staying up at night, that's what keeps me up. I'm like, okay, I don't have control of that. So what do we do? How do we partner around this?
Yeah, no, thank you for sharing and being so honest about kind of where you are on this. Jeff, I might turn to you with that same question. And Maribel, you answered, you didn't just identify the challenge, you talked about how you're trying to address it. So thank you for sort of adding that in your responses. Jeff.
Sure. My worries have actually changed over time, even from the last 90 days. I mean, 90 days ago, I was really focused on, are we going to get 12 months? Is that really going to happen? I can tell you now, having our legislative session end just a week ago, I feel better about having the 12 months and now, 14 months. And that feels a little bit better. It feels like we have a little bit more room. Sadly, I was kind of hoping we get a lead off and be able to start a little bit earlier. And CMS has told us that we can do so, but that also starts your time earlier. I think what states are really saying, can we start early and still get the 12 months? And we're going to not get that exactly the way we thought. But that was a worry early on, and I don't have that one anymore. And we talk about the enhanced funding and how that's going to dry up at the wrong time in this whole thing. And there's an argument to be made there. And I know the financial folks will really be upset if we don't at least mention that. But I tend to agree with what Maribel's saying. We certainly are concerned about the workforce. I was reporting 90 days ago that 15 to 20% of our workforce that will be handling these applications were really new or have been hired during the PHE. That's wrong. It was actually closer to 33%. I've got 1 in 3 workers that has never taken negative action on any type of a Medicaid or CHIP. Well, it's some CHIP cases, but not Medicaid cases. So it's going to be new. It's going to feel different. They don't know anything other than the PHE determinations that they've been doing, and that's going to feel different. So how do you get the staff on board with you to make sure that their focus is on retaining coverage instead of, hey, I've got 5,000 cases on my desk and I need to get this one moving through. So that's going to be an interesting dynamic to try and work through with the staffing alone. And again, eligibility systems are big ships, and they take a lot to steer, and you have to know where you're going well in advance. And we don't have that kind of runway here. So hopefully planning to make sure that the system can support those workers, that also is worrisome to me. And I don't know about it, and I guess the final piece we should talk about is member communication. And I think that's the same thing you're hearing from Maribel. There are so many strange little nuanced things happening. So again, from the CHIP perspective, we stopped charging CHIP premiums. We normally charge CHIP premiums on a quarterly basis. And we stopped doing that during the pandemic and didn't turn those back on, even though we turned the regular eligibility back on to a far extent for CHIP. So we're going to start those up. And when are we going to do that? Well, as the PHE ends, of course. So as we look at cases and renew them, we're going to start those premiums going. So from the members' perspective, they haven't been paying premiums. In some cases, they haven't been doing their renewals, and nothing's happened to them. It's just been life goes on as normal, right? What's going to feel different to them? How will they know that, oh, this renewal or this premium, these things actually matter? This time you must actually respond or your case closes. And then Maribel hit it right again. What happens is you're going to end up closing the cases. You'll see a little bit of a lag time as it takes them a minute to figure out, oh, wait, were they serious? I went to the doctor and my card doesn't work today. And then all of a sudden the applications will ramp up. And I think that goes back to what you said earlier. Our dashboard is intended to show what's going on in the application world as well, because you do still need to make sure you're doing your applications, you're treating them in the timeframes that you've established in your state, and that those are moving forward. But I believe we'll see both the call wait times are going to go up and the applications are going to go up as we're moving through. So month 1 might be bumpy, just trying to figure out what you're doing. Month 2, you might get a better feel for how that review process is working. And month 3, oh, by the way, here's some extra applications to keep you busy. It's going to be a really, really interesting time to watch. And it's going to be, I think, very important to be transparent about what it is you're doing. That was the top question that we got when we closed the CHIP cases, like, well, what happened to them? Where'd they go? And it's not a good answer. It's not good enough to say, well, gee, we really just don't know. You can't say that. They're going to want to know where. So it's just something to be thinking about, being able to say where people went, why they went there. So I think Marvell really hit them all. Those are the same worries that I'm having. And you'll probably see a little bit of a shift, even as I'm speaking, from going into the high level worrying to the more, hey, we're down to the day-to-day now. I am worried that if I get 60 days notice this afternoon or tomorrow or Monday, is Utah ready to go? And the answer is no, we're not ready to go right now. So we have that new option that we can start 60 days earlier and start processing right now. We're not ready. We're not ready to do that. So not knowing the timing is difficult, but our job, I think, as a state is to be ready that when we get that 60-day notice, you can say, okay, here's the plan. You've already shared it with everybody. Here we go. Let's move. So that's what's keeping me up at night right now is making sure we're going to be ready.
Yes. So none of you are going to be sleeping in the near future. So, Audrey.
Yes,
Yeah.
I was just going to say, I feel like sleep deprivation is a very common theme in talking with state officials that I work with and across the country that we hear from about this. There's a lot to keep us all up at night that I know is keeping all of us really, really busy. So I'm happy to pick up just on challenges, and I would just echo the point that Jeff made too about, this is a meta level event happening in the coverage landscape, and sort of tracking who ends up where. I mean, at the exchange in Massachusetts, speaking from the state-based marketplace perspective, we'll be able to see which people came from Medicaid into our marketplace coverage, which is great. But if it's not 100% transition, and it wouldn't be, it will be difficult, I think, for our state and others to be able to tell, well, you know what, this many people, we can't see them, they're not still in state coverage, but they may be in employer-sponsored insurance. But I think, again, the more detail we can get around that, the better we'll all feel as program administrators and policymakers, because we don't want to see coverage losses. So I would just echo that interest in sort of data and trackability, even though we may not have the perfect data tools as states collectively. A couple other challenges I would just point out, in addition to the great ones that Marivelle and Jeff pointed out. From the marketplace perspective, a few of the challenges that we're really focused on relate to affordability. And as I'm sure people on this call know, we are in year 2 of expanded premium tax credits and premium subsidies made possible through the American Rescue Plan that was passed, actually, I think it was 1 year ago today, which provided tremendous new affordability support to people who get covered through marketplaces. It expanded how much subsidy people could get. People who were already getting subsidies before started to get more, and then newly moderate income people started to become eligible, whereas they had previously not been eligible for any help at all. And so one of the things we're laser focused on is we're watching to see if Congress takes action to further extend those, making them available for longer or even permanent, as the president noted in his State of the Union. And that matters a lot here, because we want to make sure there's sort of the softest landing place possible from an affordability perspective for people who may be losing Medicaid eligibility and migrating into a marketplace. So it would be a really challenging time to lose that extra subsidy if the PHE ends this summer and people start to trickle out of Medicaid programs through the fall and into next year, right at this time when we're losing that extra help that's made coverage that much more affordable for people. So wanted to highlight that as sort of a top concern. Again, an uncertainty right now. This is in Congress's hands. We're watching with bated breath to see if they take action to make that affordability support extended, helpful to people who are already in marketplaces who depend on it, and of course, millions and millions and millions of more people who will be coming out of Medicaid eligibility perhaps around the same time. So that's one area that I would highlight. Another is, particularly if we are operating in an environment where, again, not officially known, but if we are to be assuming a potential PHE extension again after the April 15th, that would take us through potentially mid-July. In marketplace land, that starts to abut against open enrollment systems preparation. I know our colleagues in Medicaid operate at a very kind of rolling basis in a lot of regards, but in marketplaces, that summer into fall period is really a lot of heavy, complex systems work, determining, preliminary eligibility and loading new rates and new plans for the following plan year. So just a kind of a systems dimension that we're starting to become mindful of with each of these subsequent extensions we've been seeing of the PHE. So wanted to flag that as sort of a systems intersection and also a communications intersection, since that's normally when we're going out to talk to people about the upcoming plan year. And I think overlapping messages to different populations would be a complexity we need to be really careful of and mindful of. A couple other flags and sort of challenges that we're thinking about deeply and preparing around are for people migrating from Medicaid into marketplace coverage. How do we think about network differences and provider disruption? So we're right now doing analysis to compare provider networks in our state's Medicaid programs with what we have at the exchange and how that varies by region and program type, et cetera, because we want to be ready to anticipate whatever kinds of care issues people might run into once they do make their way across kind of the eligibility line. And yes, we got them into coverage, that's our goal, but also are there going to be issues for people on the other side of that in terms of networks and provider access? So we want to be kind of anticipating. It's not just about getting somebody into the door, it's also about making sure that their experience once they get to the marketplace is what they need and expect. And similar to that, in addition to network dynamics, again, I'm sure people on this call are mindful of this, but there are unique features to getting and maintaining marketplace coverage that can be new to people if they have not been in an exchange before, in a marketplace environment before, particularly as it relates to subsidies. For example, the subsidies people may qualify for from an income perspective are baked into your taxes. It's a tax credit. You have a tax liability when you get a subsidy through the Affordable Care Act in a marketplace. That's something we need to make sure people understand. We need to make sure people know they need to update their income if it changes during a given year so that they don't face a clawback at tax time. So there's some kind of nuances to the marketplace experience that we feel a responsibility to get people ready for. Some of these people who may be coming back to us, maybe they were with us before and it comes back to them and they remember it, and that's great, but we shouldn't make that assumption. And we want to make sure, again, in the spirit of our job is not just to get people from one coverage source to the next, it's to make sure on top of that, that they're ready to be here and ready to maintain that coverage, and they have a really fantastic coverage experience with the marketplace. So that's the last flag I would add in terms of those steps we want them to be prepared for and supported for.
Yeah, no, thank you for talking about that. Marketplace coverage looks different and feels different than Medicaid. And so making sure that consumers are prepared. Okay, I know the time goes so quickly, and I knew this would happen with such three great panelists. So I did want to just ask a question about partnerships. How are you all thinking about, partnering on the Medicaid or CHIP side with your plans? Audrey, you've talked about kind of, I think, some of the best practices of partnering between marketplaces and Medicaid. And then also, how are you partnering with community groups? How are you thinking about really getting, support from that side of the equation while you do your work? So I don't know, I'll probably just go back in the same order. Maribel, just give you the first crack at this about what's happening in Colorado.
Sure. One of the silver linings there's a lot of silver linings here as well, right? That we've taken advantage of opportunities. I've made a lot of new friends. We've had a lot of engagement with our community partners. And it feels like, okay, we identified maybe this group might need some more support. So who's engaging with that group? And then that opens up another group. And then they're like, well, go talk to this group and go. And before I know it, I'm like, oh, we have a whole new partnership. So we've been very transparent and engaged with all of our advocates and community partners from the very beginning. I've had sessions with them where, hey, this is what we know. And what we know is that we don't know when the public health emergency is going to end. And so, as I mentioned at the beginning, we've had a lot of conversations about what can we do more, better, less, different? How do we collectively think about this? One of the engagements that we're doing with them that I'm really excited about is our community partners are taking the lead as far as Update Your Address campaign. So we're taking definitely initiative on that. We've partnered with them on the messaging. They're probably going to kick off something here in the next month or so. So there's that work right there. And then there's also some engagement that we're exploring right now with our plan. So we actually have some sessions coming up where we're going to dig in a little deeper about what does our partnership look like, not only from updating addresses, but is there opportunity there for support for the renewal process? I'm going to go back to even supporting focus populations such as individuals that are disabled or our homeless population. Is there any partnerships there that can occur as well? So we have some of that, and then we also we've been also having a weekly meeting with our eligibility sites, very much in lockstep with them about, here's where we're at, and then vetting some ideas with them. So when I talked about our systems and our operations that we've been preparing, a lot of it has been with their partnership and getting their input ahead of time before we roll out widely. And of course, we've been talking about marketplace. So our marketplace, we also are Connect for Health Colorado. We have a weekly meeting with them where we've been talking just general operations, but then inserting the end of public health emergency. And we've recently even expanded it to where it's our eligibility, operation systems, and our communications, all of us coming together to have that holistic conversation about how do we leverage our current systems, what's the messaging, how do we make sure that there's transparency on what the transition looks like between Medicaid CHIP Plus to our marketplace partners. So quite a bit of partnership, and I'd be remiss to not also say there's partnership even internally within our agencies, even with our SNAP and Colorado Assistance partners, and then even within our own Medicaid agencies. I think it's really strengthened all of our team efforts and teamwork to just come together to do the best that we can for our members and for our eligibility workers at the end of the public health emergency.
Yeah, no, thank you for sharing. It's always good to hear when the challenge can bring people together, right? And so new opportunities can arise. Jeff, how are the partnerships looking in your state with your plans, with communities? What are you all working on?
It's been an interesting process. The health plans actually reached out to us before we reached out to them, which shows how much people care about what's happening in your state. We are a heavily managed care state, so we have a lot of that in our state here. We had pre-existing a file that we shared with them each and every month to say, here is, with your particular health plan, here is who's coming up for renewal. And we have continued that process during all this time. So that's one of our early touch points we have, so they at least know who is coming up and can at least encourage that to occur as well. So it gives another point of contact. I think the health plans sometimes are a little closer to the clients than we are in some cases, where they're seeing their pattern and maybe they have them in an office and where they can get to them and say, hey, your renewal's next month, and they can help that to occur. They will also reach out and call them in many cases to try and help them along. So that's one place that was kind of pre-existing that we're going to go ahead and keep leveraging. A new one, though, was, and this was interesting to me, they don't know timely who we're going to close. So while we might tell them, here's 400 or 500 people that are up for renewal, we don't tell them at that 10-day notice, and we can, like, here's who we're closing and here's where they're going. So this is interesting. We're actually going to be able to tell people now, and we're starting this month, I hope. We're really close. We've got the files we're working out the bugs, but we're able to now tell the health plans, here of the 500 you had, here's 150 that are going off to the exchange. And that is something that they're very interested in because they often sell plans on the exchange. So that's a benefit to them. At the same time, I can tell them, hey, there's 250 people that didn't, they're falling through the cracks. We didn't hear from them. Their case is about to close. That gives them another chance to contact them. The interesting thing is we spoke to the health plans, to me, was they did not understand that if Medicaid looked at somebody or wasn't able to look at someone because of a paperwork issue, they made the assumption that they would still move on to the exchange. That's not true. Most of us that deal in this world understand that that's not true. So I think that was an eye-opening moment for them. And all of a sudden they had a little bit more interest in, so we need to help you find those guys to, one, find out if they qualify for Medicaid, or two, send them to the exchange. So they have a financial interest, I think, in making sure that occurs. So that's a good place to leverage that environment if you have that in your state. I would say that going back to member communication, this is where we're starting to leverage more with our advocates and saying, can you take a look at these notices? Are we close? Are we using words that make sense? I mean, we use PHE in this conversation many, many times. That doesn't make sense to most members, we heard from CMS. So how do you communicate this again in a way that doesn't bring everybody to your door day one, but brings them at the appropriate time to your door when it's time? And with that, one of the partnerships we should also be thinking of is with CMS. What does that global communication look like? What is, if there's a lot of hype on this in month one, and there's going to be, because how do you control that? You still don't want to have everyone showing up day one. That doesn't help your system. It's going to clog every opening you have, and you're not going to be able to move forward. So that's something that we need to be thinking of. And I think CMS was creative with some of the messaging that they were talking about, saying, hey, just so you know, things are changing. They're not going to use unwinding. They're going to use the terms of art to say things are ending, things are changing, and here's a list of those things, and your state will talk to you. And maybe that helps get the message out at the right time. So that's one group. This morning, I spoke with our tribes. We have a tribal health meeting, and I spoke to them. They also want to talk about are we sensitive to their membership and to the folks that they serve. And we want to make sure that our messages are global in that way, that we're not using too much eligibility speak, which is really easy for us, and making sure that it's something that someone can respond to in plain, simple terms, that they can get, know what action they need to take or not take, and then move forward. And then I think you're right on the talking in the amongst agencies. It has caused friction, and it has enhanced those relationships. Oftentimes you start to talk about, hey, I need a change. And when you're talking to SNAP, they also want some changes and they may not align. I think understanding more of what our counterparts are going through with the other programs that they have in front of them, and really understanding that a little bit better, has been helpful. And then I just want to piggyback very quickly off something Audrey said. You've got your regular open enrollment coming up. We should point out that unwinding is not happening in a bubble. This year, we are moving our eligibility system in June from the servers they're on to the cloud. That's no small effort. That has to occur. And if we don't do it right, we lose our connection to the exchange. That might be important to us. We're also merging our agencies in July. So I've got two major agencies coming together as Health and Human Services in our state.
Yeah.
And just for fun, in January, we thought we'd launch a new MMIS system. So this is not happening in a bubble. There's a lot of other stuff happening out there. I think that's a very good point that Audrey made. We have to be cognizant of all those things. And how do you fit this key thing? It's a big deal for us. It is going to move this will be a forever bump in the graph that we'll see, right? Of this event, much like 2014 was for us. So we got to do it right, but you have to understand the context. There's a lot else going on too.
Yeah, thank you for sharing that. I just wanted to ask one follow-up, and then I really want to hear from Audrey about the community work that they're doing in Massachusetts. So there are two questions that came in related to, I think, both your comments, Jeff, and Maribel's. I think folks want to clarify, are there Medicaid, so there are marketing rules, right, that address plans and outreach the plans can do to folks who have been disenrolled. And so I think one question was, are there Medicaid health plans who are doing direct outreach to members after they've been disenrolled and transferred to the marketplace? Like, when is the time when plans are able to, after they get their files about, oh, here are the people who are sort of up for redetermination, when can they reach out? Are there any restrictions that we need to be thinking about?
So there are some restrictions. You have to be careful to make sure that you're not marketing only your plan, for example, to everybody. So we're lucky in our state. I think we're very fortunate in our state that our plans tend to work together. And we do this as a team, essentially, to make sure that our messaging is consistent. Yes, we have several plans you can choose from, but the key thing is, are we making sure we pick the person up and get them coverage? That's more important than making sure they get on this plan or that plan. At least that's what we tell each other when we're meeting together. May not be the case behind closed doors, but my hope is that is the intent, that we're actually trying to make sure we're taking care of the person. So yes, you have to be careful. My suggestion would be to work with your state agency and make sure that you're not crossing any lines that you shouldn't, and just have that conversation.
Okay, great. Maribel, anyone to add to that? Anything to add to that?
No.
Okay, that's fine. Audrey, I know we only have a couple more minutes, so talk to us about your community engagement.
So as I mentioned, we've been working extremely closely with our Medicaid partners on this. Very early, we started to brainstorm together. How can we work together and kind of use the outreach apparatus that the marketplace, the Health Connector, already has? We do lots of work every year for open enrollment, and even during closed enrollment, community-based work and the like. How can we leverage that model? So that conversation was already starting to get going. And then in parallel to that, our legislature, in their debate about state spending of ARPA dollars, actually allocated $5 million to a leading consumer advocacy group here in Massachusetts called Healthcare for All. And it gave them that specifically to help support outreach around the eventual Medicaid redetermination process at the conclusion of the federal public health emergency, as well as continued outreach work that they had been engaged in over the last couple of years around vaccine outreach with a specific focus on equity. And so that is obviously a tremendous infusion of resources to outside of government to help kind of augment this whole push that we'll all be undertaking to make sure that people who need to take action and go through the redetermination process are doing what they need to do to maintain eligibility or to migrate into their next coverage source, whether that's the Health Connector or somewhere else. So we're already working closely with that partner, Healthcare for All, along with Mass Health. So we're kind of a trio working on this together. And that will be a tremendous opportunity for us to have an on-the-ground partner. And they have a really great history of working with even more kind of micro groups around the state that are particularly close to different demographics and communities that they have credibility and trust with. So I think it's a really strong model. And again, it kind of harkens from some of the really effective grassroots work that was done in our state to promote vaccine access in all different kinds of communities. So that we're really pleased to have those resources in that partnership. So that's underway. I would also note, similar to Jeff and Maribel's comments about the insurance carrier community, I think is really engaged and at the table here. And I know they're working really closely with our Medicaid partners, but also with the marketplace, because I think they're, of course, appropriately trying to think about both sides of the migration. And they have a huge stake in this. And I'm really pleased because I think, particularly because we have a very lengthy history of health reform and coverage expansion efforts in Massachusetts that the insurance carriers have very much been at the table at and supportive and engaged around. There's a lot of kind of energy and past practices to sort of draw from. So we're really pleased. And I think everybody shares a common vision here, a common set of goals, and a common kind of full throttle energy towards getting this right and wanting to use the same kinds of messages. And as I talked about, kind of evidence-based practices to make sure we're not guessing about how to get this work done, that we're really giving this the very best shot with the best data and evidence we have for how to talk to people, when to do it, who's saying what, and being really coordinated. So between all those different partnerships, we're feeling like the work is going to be immense, but we're also confident that we have the right partnerships and resources to get it right.
That's good to hear. And, you know, it's not up to just one agency, it's the collective, right? That's going to help get us to the next stage in all of this. Okay, we only have 4 minutes left. So I'm going to do a lightning round. I'm going to start with Audrey first, because she's had to wait to be third and all these different questions. So my last question for you all, and for those in the audience, we have incorporated some of your questions into some of this conversation. So thank you for sending those in. What would be most helpful to you and your program in terms of planning? You know, is there something where the feds can do, something where the partners can do? What is your sort of idea on what could come next?
So I guess I'll say kind of the elephant in the room, which is certainty around timing. And I know there's limitations around that on the part of our federal partners. And I know they're doing everything they can to provide that. So we're very appreciative of that. But I think that's kind of the most obvious piece, is sometimes, you know, we'll be kind of gearing up and all, you know, everybody's sort of ready to go. And then it's like, no. So obviously certainty. And I think, again, to the point Jeff and I were both making, a federal awareness that this timeline is not going to occur in a bubble. Is, I think, appreciated not just atmospherically, but critically important. I would also say, to the extent that there are opportunities for our federal partners to you know, express or allow for flexibility around particular rules that could make this process perhaps abrasive to people or to the programs that are going through these changes, anything they can do to kind of soften the process as we're all trying to get through this as best we possibly can, again, with all shared goals. So I think any flexibility that can be provided around particular rules that maybe normally have to be really tight, but maybe this particular year, if there's any way they can loosen so that we can all get this work done as efficiently as possible in getting people from point A to point B, that would probably be my request.
Your request. Yeah, no, thank you. And just on that one point, we had heard some data exchange pieces between Medicaid and SBMs, and, you know, updating guidance perhaps to allow some facilitation of that data exchange, especially when you don't have an integrated system like you all do in Massachusetts. Maribel, and then Jeff gets the last word. So yes, go ahead.
I think same thing as Audrey. I mean, you know, our request is for certainty, and, you know, Jeff alluded to it too. You know, maybe, I know we've committed 60 days, but, you know, if we could do at least 90 days, you know, just to make sure that we have a really good period of window, I think would be super helpful for us. You know, the guidance is tremendously helpful. So continued support around the sessions and the conversations, and, you know, the cliff notes around the guidance, I think would be helpful for us as we continue our checklist of, are we there, and how much more do we need to make sure we're in a good place. And then, even to an extent, I know this is a little bit more challenging, but the funding, I think the funding around this is still something that's outstanding. And, you know, who knows where we'll go, but, you know, enhanced funding to continue support our continued coverage and our continuity for our members.
Yes, no, thank you for sharing that. And Jeff, you get the last word.
Sure. For me, I think it's continuing the conversation and making sure that we as states someone's going to have a really good idea, and how do we get that good idea out to everybody as quickly as possible? I think we should be talking about sharing our plans. We should be talking about good ideas and making sure that we have the context and the ability to talk to CMS. I am feeling more urgent, or more urgency, as we're moving along. We were talking to CMS once a month, and now that's jumped up to once a week. Is that signaling something? I mean, we're looking at how do we get ready? How fast can we move? And because of that, as little questions come along, one little tiny stumbling block can cause you to hold up and not get something else done. It's nice to have those communication points where you can say, hey, what about this particular issue for our state? We're trying to figure out what to do with this. What is the answer? Let's move on. And getting that urgency back in place. If you have not had a meeting of PHE Unwinding today, I have one this afternoon, you should probably be saying, I need one. You probably had one this morning. Most of us have one in the day, in the morning, in the afternoon. You should feel the urgency. And I think that's one thing that states need to take away from this. Get ready, because it's probably coming. All signs are pointing towards that.
Yeah, no, thank you so much. And I just have to say, it's been a pleasure to hear from all your experiences. Thank you for the work that you do and continue to do as we really move towards what looks like the end of the public health emergency and all the work that's going to come afterwards. I hope you get some sleep at some point. But I do really want to thank you for spending the time today. We know how busy you are. Those of you on the webinar, thank you for joining us as well. We will be, as I said, posting the recording on our website along with the copy of the slides. And you can feel free to follow up with the NASHP team if you have any follow-up questions. Thank you all, and I hope you all have a great Friday and a great weekend. Take care.